we will get started. Well, first of all, I'm Rob Cohen on behalf of myself and Steve Ports, who's helping facilitate this committee, and Donna Kinzer, and really the whole HSCRC team, especially people like Greg, who's helping this technology work, Paul, but the whole team. I want to thank you all for being here this morning as part of the Physician Alignment and Engagement Work Group, part of the new modernization of the Maryland hospital system. Thanks to everyone in the room, those on the webinar. We checked the technology. That seems to be working fine. Also, thanks to those public members who are not officially part of the work group, but we absolutely welcome your input. Thanks to Commissioner Jenks for being here. Good morning. I think I would just like to start by going around the room and let people introduce themselves and say where they're from.
Just a reminder, if you haven't already said, make sure that it's green on your microphone when you're speaking, so the folks on the line can hear you. My name is Steve Ports. I'm Principal Deputy Director with the HSCRC.
Barry Rosen. I'm a lawyer with a firm called Gordon Feinblatt.
I'm Richard Larson, CEO of Chase Brexton Healthcare.
Nicole Stallings, AVP, Maryland Hospital Association.
Good morning, Dan Wynn, Vice President, Senior Medical Director with Care First.
Good morning, Marlene Riley, Occupational Therapy with Towson University.
Scott Inner, Business Development, Cal Memorial Hospital.
Orly Panich, Emergency Physician with MEP.
Good morning, Cynthia Dow, Regional.
Ben Lowentritt, Chesapeake Urology.
Ram Paravemba, Pain Management Specialist, First Colony Anesthesia Associates.
Good morning, Rich Stummel. I'm a pathologist from Union Hospital in Cecil County.
Laura Herrera, Deputy Secretary of Public Health Services for the Maryland Department of Health and Mental Hygiene.
And I'm Stu Gutterman with the Commonwealth Fund, and I'm just sitting in on this meeting.
Yeah, thank you. Thank you for being here.
Howard Heft with Shaw Associates.
Good morning. Suzanne Dowell, Regional Lead Physicians with United Healthcare.
This is Shannon Isaac. I am the Director of the Doctor of Nursing Practice Program at the University of Maryland and a nurse practitioner at the University of Maryland Medical Center.
John Chisar, I'm a pediatrician and President of GBMC Healthcare.
Charlie Royland, I'm the Chief Operating Officer at Johns Hopkins Bayview.
Okay, is that it for everyone on the phone?
Betsy Carrier.
Betsy Carrier, Maryland Women's Coalition for Healthcare Reform Advisory Committee.
And Rob, this is John Hamper from Care First.
Good. Good morning, John. Thank you. And I think that is it for everyone who's on the phone. So thank you. I'd like to just start by saying, and I think we all know this, and many of you were at the kickoff meeting for all 4 work groups a couple weeks ago, but the goal of the new system is to deliver population-based and patient-focused care and hit what we refer to as the triple aim of having better health and better care and lower costs. So just want to highlight those as the absolute goals of the new system, and that there's really a priority placed on physician alignment and engagement, and that is what this work group is. And our charges, we'll go over them in more detail in a few minutes, but they fall generally under the categories of physician alignment and engagement, and care management is also a key part of what we're going to be discussing. I also want to mention sort of the interrelationship of the work groups. I think you all are aware that there are 4 work groups, our work group, as well as the payment models work group and the performance measurement work group and the data and infrastructure work group. And as you can sort of infer by their names, they're all quite interrelated. And as I've gone to the first meetings of those other work groups, and some of you have as well, they refer to each other. And at times there'll be joint meetings of the work groups, but we welcome people's input related to the connections. And the connections go well beyond just our work groups and things that are happening outside in other areas other than just here at the HSCRC. And some of those things are represented by people in this room as well. Dr. Herrera, the SIM program, Dr. Kahana and Nicole Stallings, the work that's going on at MHA with transitions of care. So I just want to say that this is, we really want to have a broad and open process that makes us efficient and connects all the dots, and so that we welcome input coming from lots of different areas as we try to transition to this new, as I said, population-based and patient-focused system. And with that, we'll jump in and start what's on the agenda of reviewing the charge of this work group and our deliverables. We've sent that out. It's the work plan. And just review the schedule a little bit and what we're going to do. So as you probably saw today, we're going to focus on physician payments. I want to thank our speakers for being here today, Barry Rosen, Stuart Gutterman, Phyllis Torta. And so we'll talk today about physician compensation, talk very briefly about gain sharing and pay for performance. That will be the topic of our next meeting. And that was, and you'll hear in terms of scheduling, from a work product perspective, our reports on gain sharing and pay for performance are due before care management. But just logistically in getting speakers, we're going to talk today more about care improvement and more at the next meeting about gain sharing. That next meeting is on March 11th. We have a number of speakers lined up for that meeting as well. I would mention that for those of you that have been following the white papers that have been submitted to the HSCRC, we have a number of white papers submitted on gain sharing, so should you care to, it would be great to review some of those in advance of the next meeting. All the authors of those papers, as well as other national experts, will be invited to present at that next meeting. So at that point, we'll have a baseline related to both physician payment, what's going on today, and a view of gain sharing and pay for performance structures that may be possible. Our third meeting is a joint meeting with the data and infrastructure work group, and I would note that the time of that, this one, it's 8 to 10. I know it's early. Our perspective was that for physicians, it may be better to do it right at the beginning of the day, but we're happy to take comments on that. That third meeting is a 9 to 12 meeting. It's what we're going to do is we're going to meet for an hour as our work group, and then a 2-hour joint meeting from 10 to 12. And after that, we view it as tentative, but we've said with the weeks of the meetings. We haven't locked down the exact dates and times of the meetings after the third meeting, but you can see it on the work plan. The website will be updated as we iron out dates, so everything will get posted to the website. Again, thanks to Greg and the team for managing the website, so putting the white papers and schedules and presentations that are made here will get posted to the website. So everything will be available on the website. And then our first deliverable is in May, when we owe a report on an overview of current physician pay models and our report on our gain sharing recommendations. And then after that, in May, we'll have meetings in June, which will focus more on the care improvement side of our task. So we'll be doing more on care improvement, including related to post-acute and long-term care and evidence-based care, and we have a deliverable in July on the care improvement aspects of what we do. So that's a quick run-through of the work plan. And maybe I'll stop there before we get to our first speaker and ask if there are any questions or comments. Please.
So I see that we have the joint meeting with data and infrastructure. I was listening in on Friday to the payment work group, and there was reference to our gain sharing work. And I'm wondering if you envision any other joint meetings, or if those will kind of be ad hoc, as needed, as requested, what your thoughts are.
So that's a really good question. I absolutely heard that. I think Ray Gray brought it up at the payment models work group. Donna Kinzer was, emphasized, and that was sort of part of what, as I got started, wanted to raise the importance of the connections. So I'm not sure at this point if we'll have a joint meeting. We may well. In any case, we absolutely want to make sure we're coordinated.
Yeah, I think the schedule is a work in progress as things, this is sort of iterative, if you will, a lot, and there may be some synergies that we may have to change over the course of the time. So there may be a point where we do want to connect with, say, the payment models group or another group. So if there is a, recommendation of the group to do that or the other group, we'll certainly change the schedule to try to arrange for that.
Yeah, and I figure as long as we've now talked very specifically about 3 of the 4 work groups and our interconnection with data and infrastructure and our interconnection with payment models, for those of you that were at any of the performance measurement work group meetings, tremendous overlap with that. I mean, at the last, so far what they've been talking about is potentially avoidable utilization and readmissions and hospital-acquired conditions. So all things that are very much in the zone of what we're going to be talking about in terms of care improvement. So an awful lot of overlap with all of them. And again, with the other work that's going on with SIM and the transitions of care and lots of other initiatives out there that are going on. So we welcome input related to those connections to make sure we're well coordinated.
And the staff who are working with each group is meeting on a weekly basis, and we are trying to connect those dots too. So at the very least, each work group is going to hear from the staff leads from other work groups about the direction that each work group discussions are going on certain topics.
Just in case anybody noticed that you probably didn't, I wanted to apologize. Since I just went through the work plan, I think Greg has already reposted an updated work plan to the website. In case anyone was confused at the April 7th meeting, we are not going to talk about uncompensated care policy. That's the old, cut and paste and started with another work group's work plan and didn't delete a line. So don't get yourself confused and think that is part of our charge. And with that, I'd like to turn it over to Barry Rosen. Many of you probably know Barry. I'm a member of the work group and just does a tremendous amount of work in Maryland in healthcare. He's the chairman and CEO of Gordon Feinblatt, which is a law firm in town that does work in lots of areas, but Barry's specialty in particular, besides being the chairman and CEO of the firm, is healthcare. Does an awful lot of work with really all sides of the healthcare field, payers, providers, physicians, but has a tremendous view of the physician community and doing contracting with physicians. And wanted to let Barry talk about physician compensation. One of the things that has come up is that in the new model, a globally budgeted model, and with hospitals being on global budgets, they will have an incentive to keep people healthy and out of the hospital. And we want to talk about physician payments in that context and the balance between, as I said, we're going to be talking about gain sharing and pay for performance. Right now, there's a lot of fee-for-service payment. I just want to sort of talk about that dynamic and turn it over to Barry to do that.
Thanks. Good morning, everybody. Part of our task is to talk about alignment of physician incentives. So we thought it might be a good idea to start out with a baseline, since one way you align incentives is you understand the incentives that exist now, which this talk is about how doctors get paid. And so if we do something that's in conflict with that, you run into an obstacle. And if you add incentives, then perhaps you can also change behavior. What I'm going to talk about are 4 models. One is, and this is the context of both voluntary docs. These are docs that are an independent practice but use the hospitals on a voluntary basis, and also docs that are on salary. They're employed by the hospital. These 4 models apply to both situations. Some are more prevalent in one or the other, and I'll touch upon that as we sort of go through this. But basically, the 4 compensation models, there is just a base salary with some bonus opportunity. There is an impact on something called designated health services, which will weave its way through all of our discussions, since DHS is about potentially overutilization of some services. Unfortunately, one of the payment models is called Eat What You Kill. It's an unfortunate name, but you'll see as we get there, at least it makes sense, although it is an unfortunate phrase. And then I'm going to spend some time on relative value units, which is rare in a private group, but becoming really quite prevalent at the hospital level. And some of those incentives may be different than some of the incentives about slowing some utilization. Yeah, and feel free to I'll keep rolling, but feel free to interrupt me during this. You know, there is a basic notion that many docs are paid a salary, a certain amount of money with an expectation that they come in and do work, and then there is the opportunity for bonus to incentivize productivity and also keep the docs from being 9 to 5, going home and not really working very hard. But there is a salary and bonus, which you often see both at the hospital level and in private practice. The most prevalent types of bonus, clearly on the private side, especially with young docs first joining practice, is a base salary, and then the bonus is some percentage if your collections are above a particular threshold. The most prevalent threshold is twice your salary. If you make $200,000, that's your base salary, but you bring in collections twice that high, $400,000, you then have an opportunity to get a bonus, some percentage, say 25% of the collections you bring in over $400,000. And that is something you see often with young docs coming in, a base salary and a percentage. If they work harder, they generate more money. Why is this rule of thumb? And again, sometimes the threshold is more than twice or less than twice, but I want to get you to start thinking about why is it even twice as a rule of thumb. The notion is there's also overhead, that the doc gets paid the $200,000, but the rent has to be paid, the doc gets health benefits, the owners might like to get a profit, so that to get back to sort of some even place, it's double that salary, or $400,000. And then above that, there's an opportunity, again, to reward the doctor. This could go in steps, that it might be 25% if you go over 400, but 35% if you go over 600, and 50% if you go over 800. Again, the notion is to incentivize the doc to do more and more. This gets you to how do you count this. In the private setting, it's usually on a cash basis. It is collections. It's how much money actually comes in. On a hospital level, hospitals are used to accrual accounting, not cash accounting. So a hospital that might have a salary plus a bonus might do it off of billings, not off of collections. There is a significant difference. Collections automatically adjust for the payer mix. Different payers pay different amounts for the same service. If you're doing it for collections and you have a lot of medical assistance patients and you're not getting reimbursed very much, and the other doc down the hall has all commercial payers, he may be getting paid more, right? On collections, he's also earning more. His bonus is higher than yours. On an accrual basis, you have to then adjust for the payer mix and some expectation out of what do you bill, do you actually collect. So it is quite different. Where do the salaries come from, or where can you get data about salaries? The baseline first. There are several companies. The leading one is something called MGMA. They will publish what they think the median compensation is for a cardiologist, for an ophthalmologist, for an anesthesiologist in the United States, on the East Coast, on the West Coast, and you can get average compensation information. It's not a terrific source. The samples are small. If you think about it, how does MGMA know what a cardiologist makes unless somebody voluntarily gives them the information? This isn't connected to the Internal Revenue Service. They don't really know what anybody makes. And likely it's a high number because only the companies that are doing well actually think about publishing the information, because if you're really in the bottom quartile and you know you're barely struggling and you think you are the lowest paid gastroenterologist in the world, it is unlikely you are going to voluntarily give your information to MGMA. Nevertheless, it is the information that is out there, and we're going to come back and talk about MGMA several times through this discussion. Other types of bonuses, there are doc deals now with hospitals where the hospitals will say 5%, 10% of your compensation is going to be determined by some other metric, which I don't know what it is, but we'll decide what it is year by year. And it might be a process measurement. If you do these things, follow these processes, then we'll give you a bonus. It could be some outcome measure. You know, we're looking for throughput or something, and we'll actually measure something, and we'll give you a bonus for that. There is no norm. In other words, there's nothing been established that these process or outcome measures are normal. They are often rather open-ended, and we'll figure it out this year, and maybe we'll do it again next year. Obviously, another bonus that's creeping in, at least for the primary care docs, is that for some relevant population, Medicare, managed Medicare, commercial population, that a payer will set a target for overall expenditures for this population. And if lo and behold, the expenditures are less, then they'll share some of that savings, often with the primary care physician. And this has some appeal since the savings really aren't coming out of the primary care physician's pocket. But if you have less hospital service, less ancillaries, that fee-for-service is leaving the hospital or the ancillary provider. The payer is happy because they're paying less, and they don't mind sharing some of it with a primary care doc who may be managing the care and keeping people healthier. This is minor at the moment. In other words, there are just a few experiments out there, not lots of money flowing, but obviously it is starting. Okay, I want to talk about designated health services. This isn't a concept of what you can't bonus a doctor for. This is the Stark Law. It's Congressman Stark from California implemented a law that says many things, but one of the things say you can't bonus doctors for certain referrals. These are things that a doctor writes a script for and says you need a blood test, you need an x-ray, you need physical therapy, and you're not allowed to bonus the doctors for these things. Radiology lab, orthotics, prosthetics, physical therapy, with the exception of incident to physical therapy, you can bonus a doc for. Durable medical equipment, all in and outpatient hospital services. None of these things you can be bonus for. So I can't say to a doctor, either in a group or at a hospital, look, every time you order an x-ray, I make $10. I'm sorry, I make $100. So I'm going to pay you $10 every time you order a lab test, every time you order an x-ray. I can't pay you bonuses for that, because if I were to do that, I would be encouraging potentially overutilization. The hospital can't give you $10 every time you admit a patient to a hospital. They would be paying you a designated health service, hospital services, and you can't give bonuses, for that. There are workarounds, however. Notwithstanding there is the prohibition, there are things within this context that are legal. You can pay on a per capita basis. We can say to the doc, you can't get a $10 for every x-ray, but we'll pay you 5% of all the profits on our x-rays. You may be a big X-ray user, a low X-ray user, but you're already set in, you get 5% of it. They also can be paid on a proxy basis. We won't measure how many X-rays you use. We'll measure something else. You are the busiest doctor in the practice. You can have 30% of the X-ray profits. I don't know if you're really doing 30% of the X-rays. I'm not allowed to do that. But I know you're just the busiest, so you can get the biggest amount. A lot of practices take the profits from these ancillaries and simply reduce overhead. They say, look, we got all this rent to pay and so on. We'll take all the ancillary profits. It reduces overhead, and that theoretically allows more for the docs. We're going to get to that in a minute, how overhead's important on Eat What You Kill. Hospitals rarely do this, but there are some tricky ways that hospitals can create their own practice groups, and within the faculty practice plan, they actually can distribute profits from DME, not on a dollar basis, but sort of on these per capita kinds of concepts. You run into it very infrequently, however, where the hospitals are trying to be that tricky, but it is there. They can create their own practice groups within a group of docs, and they can do some. They have some flexibility within their group faculty practice plan to encourage and pay for these extra ancillaries, which have historically obviously been paid also on a fee-for-service basis. All right. Most docs in private practice, and also many docs at hospitals, are paid on an Eat What You Kill basis. What this means is the doc is personally generating a certain, as an economist, you should think about this as a disaggregation. This takes the business of medicine and brings it down to the doctor level. And it's just a cottage industry. Each doctor is a separate business, right? And so this doctor produced this much revenue himself or herself. That's their revenue. You then give them a share of overhead, and what's left they eat. They eat. Whatever that's what's left. They take that home. That's their pay. And often this is the normal practice in private practices. It looks like a large group, but it's really just a bunch of office sharers that are in business for themselves, each one taking home whatever it is they personally generate. Obviously, it incentivizes them to work hard. When I say less your share of overhead, there's a whole range of ways of doing that. General overhead, the rent, that might be split equally. 10 guys in a group, each one pays 1/10 of the rent. Again, some groups do it on a percentage basis. Again, you're the busiest doc. You have to pay 30% of the rent, and I'm not so busy. I only have to pay 10% of the rent. Docs sometimes do the same thing with direct overhead. It's equal among all of them, and sometimes they get down to every paper clip is assigned to every doc, and that goes to his share of overhead. Often benefits, their own health care benefits, get applied to them. Some docs use very expensive drugs, and another doc doesn't, so the drug costs might be allocated to the doc. Some docs have lots of people working just for them. Those people might get allocated just to them. There are examples in private groups where they do set aside a pot, some centralized amount of profits, and to allow everyone to share in a rising tide. And so that everybody can be happy for each other's successes. It does encourage some cross-referral and specialization. I'm really good at knees and you're really good at spines. I really shouldn't do the spines, but when I give you the spine work to do on an Eat What You Kill, I get no money out of it. So some groups have a central pot where there is some sharing. There are also, some groups really are shift workers. And what you see is the profits are divided up much more equally. ER docs, anesthesiologists, radiologists. It isn't a matter of being more productive one than the other. You have a shift. You are there at a particular amount of time, and so you see compensation much more equal in those specialties. Clearly, also sometimes the central pot just goes to the old folks, right? The founders have taken some amount off the top, and they keep that. Clearly, but this is where that ancillary profit goes. Besides, even on an eat what you kill basis, a lot of money being made in radiology and lab work and other ancillaries within the group. That on an eat what you kill, where does it go? Because that's not what I'm doing personally. I can't get bonus for it exactly. It rises the tide, and then it either gets applied to everybody's overhead, so you get to keep more, or they've taken that pot and they're whacking it up. The biggest difference often between owners and employees in physician groups is the owners keep the ancillary profits and the employees do not. Often some groups also take management fees off the top, and some small select group of owners might in fact be making money on that management fee that's coming off the top. And again, before we get into relative value units, the hospital models up to the relative value units are somewhat similar. You see salary plus bonus, and you see eat what you kill formulas. A little harder to figure out your share of overhead in a big organization. So sometimes it's just a percentage. Your revenue, some percentage of your revenue is taken out for overhead, and it isn't a specific calculation. What's new, there are a few groups that use relative value units, but what's new is the Maryland hospitals and hospitals all around the country are paying docs, especially community hospitals that are just new to hiring many docs, are paying them on a relative value unit basis. And as you know, Medicare, for everything a doc does, every single procedure that a doc does, has a relative value unit for it. And in a second, I'm going to show you some examples of that. And then, so you can take any doc and you can say, this is how many relative value units you did. You did a little of this and a little of that, and we add them all up, and that's your relative value units. You then have to multiply that times a conversion factor to turn it into dollars. You did 3,000 relative value units, and at $50 a unit, we're going to pay you 3,000 times 50, and that's what you get paid. So you have to count the relative value units, and then you have to multiply it by a conversion factor. Here's an example of that, which is, this is a spine surgeon. They've done, in this period, annual, monthly, quarterly, whatever it is, they've done 117 lumbar spine fusions. They did 7 more with a modifier of 51. They read a lot of lower spine x-rays. They had office visits for new patients and office visits.
It was listen only, so I couldn't.
And office visits for established patients. And you take what they did, multiply it times the relative value unit, times the frequency, and you know they did 3,472.96 relative value units.
Listening, I can see. Yes, I can, but I couldn't.
Okay, somebody's talking. Why don't you put it on mute, one of the folks on the phone.
Yes,
Thanks.
we'll introduce you after the presentation.
Okay. So on the 3,472.96 RVUs, this doc's deal was they got a base salary as long as they did 3,200 RVUs. So this doc did 272.96 extra RVUs. That was their productivity increase. This doc's pay is being multiplied by $53.25 as the conversion factor. So this doctor gets a bonus of $14,535. The docs clearly be encouraged to do RVUs. Some docs, the whole thing is RVUs. They have no idea what they're making until you do the RVUs. Sometimes if their RVUs go down, their pay then goes down, or they owe money back, or they have upsides. Again, this you can see this in steps. It might be $53.25 for above 3,200 RVUs. It could be $60 above 5,000 RVUs, $70 above 8,000 RVUs. You remember the 5325 as a similar overhead concept. The payers are paying more than 5325. They're paying $80 or $100 per RVU. Some of this money the hospital needs to pay for overhead, so they have trouble giving the doctor all of it. Where does the conversion factor come from? So far, most often, it's again coming from MGMA. MGMA will tell you what the 50th percentile cardiologist produces in RVUs. MGMA will then also tell you what the how much a 50th percentile cardiologist makes. You then divide the RVUs into what they make, and you get how much should they get paid per RVU. I mean, this is now a spine surgeon, but it's here $53.25. You have to remember that the ancillaries, however, in private practice are actually built into that number. The spine surgeon is making money on the x-rays, so if you divide their RVUs into their average comp, you are actually including the ancillaries in that computation. I'll get to that in a minute. Okay, RVUs are an odd comp way to pay anybody. They are, first of all, although not necessarily divorced from cash, they are divorced from cash. In other words, RVUs for a medical assistance patient, a Medicaid patient, is an RVU. It's the same as it is for a commercial patient. That is nice and equitable and fair. It also doesn't have much to do with cash, since you're getting paid different amounts. So if you're paying two docs on the same basis, the same RVUs, and one has a different payer mix than the other, one doc is generating more money and one doc is generating less money, but yet they're getting paid the same amount if you're doing it on a WRVU basis. The reason I'm saying it is divorced from cash, but not theoretically, you could every year go back and look at either the doc's payer mix or the group or the hospital's payer mix and change the modifier. And that, in fact, at the end of the year, given the payer mix, you can figure out what did we get paid for all of these RVUs, and then the modifier would change. Docs clearly don't like that deal. If you're trying to get them to come to work for you, and you're saying, come to work for me, I'll pay you on RVU basis, you can stop worrying about collections, you can stop worrying about payer mix. But I'm not going to really tell you what the modifier is until the end of the year. The docs may say, I'm going to stay in private practice, thanks. I really want to know what the modifier is, at least for some number of years. So it's hard to make that transition to hospital employment unless the hospital says what the modifier is. It is also divorced from overhead. Again, theoretically, it doesn't need to be divorced from overhead, but it is. Again, you're trying to attract that doc, and you're saying we're going to give you the $53.25 no matter what our overhead is. Usually the hospital's overhead is much higher than the private doc's overhead, so you've already built in to give that doc the same amount of money or a raise to get them to come join you. You are at a loss. In other words, the hospital is already working at a loss, and the HSCRC has clearly documented that Maryland hospitals have mounting losses in their physician practices, not only because of this, but in part because of paying on WRVUs. There is some extra revenue that the hospital gets that the private doc doesn't get, and that isn't a subject for today, and it's people at the HSCRC understand this better than I do, but there is clinic revenue, that there are some situations where a private doc, if he saw you in his own office, just sends you a bill. He becomes a hospital employee, sees you on the hospital campus. He now gets to send you two bills, one for his services and one a clinic visit service. So there is some extra revenue that the hospital picks up. The next odd thing about relative value units, they are again divorced from designated health services, partly because Stark says they have to be. The hospital cannot keep track of the lab work that you generate. and figure out what your pay is based on your labs or your admissions, that would be illegal. Whereas, again, as I mentioned before, if they worked in what MGMA says what the voluntary cardiologist makes into their conversion factor, they have actually counted the ancillaries in that number. The RVUs change on an annual basis. They used to change biannually. They now change on an annual basis. So how many relative value units you get for a procedure does change each January 1st. And there's a big date coming, 2019, part of the Accountable Care Act. You may have known that at the moment Congress sets the conversion factor for Medicare. And so for years that was supposed to go down by 20%. Of course, it never did, but it did stay flat, or relatively flat. But in 2019, a panel, not Congress, has the right to change the way Medicare pays doctors. And everybody's crystal ball is their own, but one can easily imagine clearly one thing the panel will do will take high-frequency, high-priced items and say no more. We're not going to say that's how many relative value units you get for a lumbar spine that has a whole lot. We'll cut it in half. And now that's the relative value unit for high-frequency, high-pay items, and people getting paid on a relative value unit basis. Things could clearly change in 2019. All of these, RVUs, bonuses, and eat what you kill, clearly incentivize people to do more. But you got to remember, if you don't do that, humans get lazy. And clearly the hospitals have an experience in the 90s. They hired docs. They put them on salary. The docs didn't do much. The hospitals lost a whole lot of money, and they regurgitated, by the end of the 90s, all the docs they had bought during the 90s. So if you don't have some productivity, then it's really hard to run a business. And that's my attempt at a baseline.
No, that's very helpful. Thank you, Barry. I think it's important for us to sort of understand the baseline as we think about where we're going. As I said, at the next meeting, we're going to have people talk about pay for performance and gain sharing and what can be done without certain types of approvals, what types of structures need certain types of approvals. I did want to point out, I did circulate the work group descriptions of all the work groups. I just wanted to drill down a little further and really highlight that our charge as a work group is to put forth recommendations, specific recommendations, about how we can better align physician incentives with hospital incentives. And I also think it's important to note, because I know people have asked, that the HSCRC does not regulate physician payments. Physician payments, for example, from Medicare or fee-for-service will continue to be fee-for-service. But at the same time, the question is, can we create incentives through shared savings or gain sharing or pay for performance where there can be incentives to, sort of separate from eat what you kill or RVUs. Barry did highlight that there are some other, while he said there's no norm, there are other examples of models where physicians get bonuses for doing certain things. But you'll hear at our next meeting examples where you're looking at quality of care for treating high-cost users, or you're reducing admissions for people with CHF and COPD. Can you reduce ER admissions? There's all types of things. Can we create incentives to do that? And one of the reasons that we're doing it here is that the thought process is, again, while the HSCRC doesn't regulate this, can it facilitate it and make it easier by helping to coordinate the industry? Is it more efficient and cost-effective? And can we facilitate getting approvals in a manner that would be easier for hospitals doing them individually? Some of you have probably been involved in gain-sharing efforts to date. They've primarily been cost per case focused. At least the ones that I'm aware of, have to do with managing the cost of the case. Under the new system, we have incentives to manage volume, and so I think that's a place where we might be able to come up with things that are innovative and different. It will be important for us to do that compared to some of the gain sharing mechanisms that some of you are probably familiar with. But again, I just want to point out that that's the ultimate charge of this work group, is to come up with recommendations about how to truly align incentives in a better fashion. And with that, I thought I'd just open it up and take comments or questions from the work group.
I've got one. I have the fortune to be on the front lines of these contracts. I can tell you nationally, particularly those groups, both employed and large physician, that are heavily invested in collaborative care, whether it's ACO models, gain sharing arrangements with private payers. That percentage, that incentive pool, is growing dramatically. You're seeing baselines for primary care of 20%, up to 40 or 50%. And they're not based on volume of work or collections per se, because the group itself is no longer being paid that way. So it's all about following the money, and where you're seeing it is on baseline to get into the pool of productivity, followed by quality measures that align with whatever contract, how that groups get paid. The other note I'll make is on WRVUs, there are private groups that are using, I know at least one successful one in Annapolis, where they are resetting it, whether it's on a quarterly basis or an annual basis, based on their collection rate, that rate. The WRVU model is both inherently flawed because of the way the AMA sets it, heavily specialist dominated, but also very equitable within a group, because it does make the cherry picking issue. It makes the physicians and the staff more payer mix agnostic within the group. Obviously, the group itself still has its preferences.
So I have a few housekeeping issues. If you can identify yourself before you speak for the people on the phone and speak to the microphone, I would appreciate it.
Sorry, that was Scott Intner from Calvert.
Thank you. Later is fine too.
This is Howard Haft. I have some 20 years experience also with multi-specialty groups, both hospital-owned and independent. And I've echoed the last response, and I've seen a significant increase in this much more balanced scorecard approach to compensation plans, which includes a significant portion for measured quality, for engagement or citizenship, for patient satisfaction measures, really again mirroring what's now required for for ACO or patient-centered medical home participation. So kind of aligning all of those incentives in a straight line. So if you're doing the right things, that you're doing the right things for your patient-centered medical home, for your ACO, and for your hospital. And I think that's really the art in what we're going to be doing here is taking what's very complex, a very diverse group of types of providers, hospitals, non-hospitals, small, large, medium, rural, urban, suburban, independent, etc., and finding a common thread that people can align along. And I don't think it's to create new threads or new outcome measures. It's to use those that we already know are being incentivized and link them together in a simple framework. There are already a number of programs that the Care First multi-payer program, which has, again, the same alignment, the MMPP program, which has the same alignments that actually provide significant bonuses to providers. Now, these are primary care providers. They're not a whole range of providers, but I think that's also part of the challenge is how to make one system fit all types of providers, primary, specialty, hospital, and non-hospital.
Thank you, Dr. Haft and Scott. And I think those are helpful comments to know what's going on with incentives today, and to hear that they're growing, and to also hear that they are starting to happen in Medicare through ACOs and through other demonstrations. I do think that's something we very much need to keep in mind is Medicare, that as you were talking about the increase in incentives from private payers and commercial payers, but still Medicare fee-for-service is the biggest single payer, and it's great that there are structures that are starting to enable and make incentives happen in Medicare, but I think that's a place we need to focus. Because I don't know, if all of Medicare isn't going to be in those structures, the question of can we create the ability to do gain sharing or pay for performance that expands throughout the entire Medicare fee-for-service population. So if hospitals are under global budgets and have incentives to manage the whole Medicare population, maybe it's not sufficient to have incentives only related to those Medicare patients that are in demonstrations or ACOs. I think that's something we need to think about. I'm sorry, Dr.
This is Dr. Paravemba. I'm a hospital-based physician with First Colony Anesthesia. I just wanted to comment that thanks for the presentation, Barry, that there are some differences between physician types, and hospital-based physicians would be a unique situation where volume isn't necessarily driven by the physician. You can't necessarily go out and market doing more anesthesia cases. The volume is driven by multiple factors, including the different types of cases that come to the hospital, the case mix that comes, and we have to adjust the compensation fairly and equitably among the providers in that hospital based on all those factors. We actually use the RVUs to calculate physician compensation in our hospital, to be fair, because it adjusts nicely for different payer mix, and it also adjusts to a certain degree to the type of surgery that we're performing and severity of illness for the patient, which is very important to adjust for in the compensation scheme. So I think going forward, the hospital-based physicians are going to be very important in driving down costs, and they'll be able to, if incentivized properly, drive programs that could dramatically reduce costs. In fact, in the short term, I see them as playing a very vital role until population health improves, and we can keep patients out of the hospital, which would save more money. So I just wanted to make those comments that different physicians may have different ways of incentivizing themselves to provide more value-oriented care.
Absolutely, and thank you.
We have some new members joining late, so if they can introduce themselves first. Let's start in the room, and then we have one person, I think, online.
Hi, I'm Phyllis Torda from the National Committee for Quality Assurance.
Thank you. And anyone online who joined as work group member?
Hi, Sid Gottlieb, I'm a cardiologist. I've been listening, but I was muted at the beginning. So.
Thank you. So as just another housekeeping note, all work group members are unmuted, so you need to mute yourself. And the one who are joining from public, we are muting them all, and we're going to take the questions at the end. Thank you. And by the way, I'm Shule Cholko. I'm from HSCRC, and I was also late that I didn't introduce myself.
Thank you, Shule.
This is Barry Rosen from Gordon Feinblatt. I had one other thing to mention. Rob commented the HSCRC does not regulate physician compensation. That's correct. But there's other ways to change behavior beside either incentivizing it or prohibiting it or regulating it, and that's just asking about it. And the HSCRC does have the ability to ask questions to the hospitals and require hospitals to report. It could ask each of the hospitals Are you paying on what basis? Are you paying for on-call? Are you paying an RVU basis? Whatever basis it is. Also, they could ask how much you're paying, for that matter. The notion that no one likes publicity, people are embarrassed about publicity, people change behavior depending on where they are in a list. And there's also sort of the George Steinbrenner kinds of reaction is, please protect me from paying too much. And that the HSCRC, by collecting data, actually could change behavior without regulating anything and just asking the question and publicizing it. I'm not advocating, but I am at least pointing out there's another way to go at some physician compensation impacts. Thanks.
Thanks, Barry.
This is John Chisar from GBMC Healthcare. I just want to make the quick comment. There was a previous comment made about accountable care organizations and structures managing the health of populations within one payer. And I just wanted to point out that there are already physician groups that are managing across all payers that are pretty good examples to study.
Dr. Chisar, thank you. That's helpful. And I've heard it mentioned a couple of times, this notion of sort of all payer structures and coordinating across payers and using metrics and things that are already happening as opposed to starting over. And we hear those comments and appreciate it.
Because it's incredibly disorienting to providers of care to try to set up different rules according to payer, and it goes against the training of most doctors and nurses to treat people differently according to payer type. So I think the more sophisticated models out there are managing populations and just dealing with the multiple sets of rules.
Thank you. We'll certainly have an eye towards that. Appreciate it. And before we turn over to our next speakers, any other comments? Well, thank you. And as I said, we'll continue to come back to these two things: compensation models and care coordination. So the rest of the day, we're going to focus on care improvement, and want to really thank our two speakers today, Stu Gutterman and Phyllis Torta. I know both of them have been impressed by both of their work for a long, long time. They both have long careers in health policy and tremendously relevant and great views of what works in healthcare and can offer some thoughts about that. Stu Gutterman from the Commonwealth Fund has been at CBO and MedPAC and CMS. At the Commonwealth Fund in particular, he's focused on innovation in Medicare, and I think that's a key area we need to focus on to be successful on in our new model. Phyllis Torta, Dr. Torta, is at NCQA and runs their Quality Solutions Group, and again has lots of experience working with various models that improve quality in healthcare, and NCQA just, I think, does a great job of leading the industry in the direction of metrics to drive quality, and Phyllis has a good view of that. So I look forward to hearing from both of them, and we'll turn it over to Stu.
Thanks, Rob, and I am really privileged to come talk to this group. I am a member of the payment models work group, so I'm involved in this process too, but clearly there's a lot of overlap, as has already been mentioned several times, among the work groups and their interests, and I trust that we'll be interacting a lot during the process. I'm going to talk a little bit about care improvement. I'm going to focus mostly on Medicare, but I should start by saying that there are lots of innovative approaches to healthcare that are being developed in the private sector and at the state level as well, including, of course, what's going on in Maryland, both in the public sector and the private sector. But there are great examples in other states as well, and among other private payers. So first, I'll start out with kind of an overview, and then I'll focus on some of the innovations. And I'm going to focus primarily on innovations that are being tried to improve the coordination of care across different providers in different settings. So start out by, kind of showing us where we stand. Everybody knows the U.S. Is the best in the world without argument at one thing in terms of healthcare, and that is spending money on it. And we are about 50% higher in our health spending than any other country in the world. So that's kind of the first striking realization that we have to face. That spending is concentrated in the healthcare sector. Overall, the top 1% of our population accounts for about 22% of spending. We're about $90,000 a person. The top 10% accounts for about 65% of our spending. So there are folks that generate a big portion of this. Most of the population is relatively healthy. The bottom 50% in terms of health spenders account for only about 3% of health spending in the U.S. So that's the argument, one of the arguments for focusing on, folks who are high users and high spenders in healthcare. Not that they're doing anything wrong necessarily. These people are spending money on healthcare because they're sick. But it demonstrates that there are people who are particularly in need of better coordination of care in our health system. And coordination of care is not what we would like it to be, particularly given how much money we spend, and perhaps that's why we spend so much money on health care. And the Commonwealth Fund does regular sets of surveys of people and providers in this country and others, and find that there's a shockingly high proportion of fairly basic coordination issues that arise and are reported by patients in the healthcare system, and difficulty in coordination obviously increases with the number of doctors involved, and that means that since folks with multiple chronic conditions see multiple doctors, they're the ones who are most vulnerable to this kind of lack of coordination. Another issue that the Commonwealth Fund has particularly been paying more attention to lately is that while the United States spends much more money than anybody else on medical care, that we actually are at the low end of the distribution on social services frequently that help support people who need medical care. And so we tend to substitute medical care for social services, where in other countries there's a different mix. And when you add the two together, work by Elizabeth Bradley at Yale found that the United States is actually in the middle of the pack among high-income countries in combined health and social service expenditures. And so we've been looking more at the role of social services to try and help reduce our overall medical expenditures, and to help folks who are sick, who need those services as well as medical care. Now, looking at Medicare specifically, there's a strong relationship between the number of chronic conditions that beneficiaries have and the amount of spending that they account for. So there are two things to draw from this slide. One is that that more than 2/3 of Medicare beneficiaries have at least 2 chronic conditions, and that those beneficiaries account for 93% of Medicare spending each year, not just for those conditions, but overall for the health care that they use. So again, there is a clear imperative to focus on the needs of that population, because they are the ones who need our healthcare system most, and they're the ones that generally our healthcare system is failing most. It's not only a question of what Medicare spends, but also the expenses that these folks bear themselves. Despite the fact that Medicare is one of the more successful public programs in history, there's still a fair amount of out-of-pocket spending for health care services that Medicare doesn't cover, and copays and deductibles that Medicare still holds beneficiaries responsible for. And you see here that folks who are in poor health end up spending, even with Medicare coverage, over 20% of their household incomes on health care. So we have to remember, and particularly in Medicare, with all the discussion of the federal budget, we're constantly having to remind folks that Medicare is not just a line item in the federal budget, but actually a social program that people depend on for access to the health care that they need. So what are the implications? Clearly, we have to find better ways of coordinating care, particularly with beneficiaries with chronic illness. There's a lot of money on the table here. You can look at the amount that's spent for these beneficiaries in 2 ways. One is the burden that it puts on themselves and the program, but also it means that there's a lot of leeway for spending that money better to improve the treatment that they receive and improve their overall ability to function. And so we need to do that, particularly in the Medicare program, where the stated goal of the program is to provide access to care, but also across the board as well. So the Affordable Care Act created a Center for Medicare and Medicaid Innovation. I've been particularly interested in that part of the agency because before I came to the Commonwealth Fund, I directed the Office of Research, Development, and Information at CMS, which I like to think of as an ancestor of the Innovation Center. We did Medicare demonstrations. We did evaluations of Medicare and Medicaid initiatives. And before the Affordable Care Act, trying to do some of these demonstrations kind of felt like trying to work with one hand, maybe both hands tied behind our backs, because there were restrictions on what we could do, restrictions on the amount of risk that Medicare could take in doing initiatives, and it's very difficult to engage folks in voluntary demonstrations when you have to say, when you come to the cliff and you say, let's jump off into a new world, that you always have to say, well, you first. Kind of doesn't encourage a view of Medicare as a terrific business partner. So the leeway that the Innovation Center has is very important. They have money up front. They have the ability to put money up front to help to develop demonstrations and pilots. They still have to cope with kind of an old world view of what of a demonstration mindset. And I don't know how many of you saw the article in the New York Times last week, I think it was, taking them to task for not using the randomized trial model in testing their innovations. And it was very distressing to folks who were close to that process, because the idea is to get away from that kind of model and to get away from the idea that you do these initiatives, you fold your arms as an agency and kind of wait for them to prove to you that they work, and instead try to help these initiatives to work and be able to do mid-course corrections to do that. It's more risky, but gain is frequently more risky to to accomplish. So the Innovation Center lists a number of areas that they focus on, and they have a number of initiatives, and I'm going to go quickly through them, and then we can talk more about them. I've, again, focused on the ones that are designed to enhance coordination of care across the system, and there are a number of them. And they really are on the next slide. Is there there we go. Okay, there we go. I think that's. We've already talked about accountable care organizations. That's a new model of care that's actually already part of the Medicare program. The Medicare Shared Savings Program is an initiative that involves now over 340 different organizations. These are groups of providers that have agreed to take joint responsibility for the quality and cost of care, and they are able to receive a share of the savings that they generate relative to a target that's set for each of these organizations based on the overall trend in Medicare spending. Now, talking about the Shared Savings Program, and there will be debate probably forever about whether accountable care organizations work. And a lot depends on how you define work. And one of the big issues is compared to what? And talking about shared savings. For instance, if an organization controls their Medicare spending now, well, Medicare spending is growing very slowly now in general. So how much better do you have to do than the overall trend? Or is Medicare spending growing more slowly because some of these models are already in effect? It's very hard to tease out those effects, and that's why you'll always have debates about whether these initiatives work or don't work. But as a physician who works on the West Coast said to a group that at a meeting that the Commonwealth Fund sponsored, what we've got right now is a system that doesn't serve people very well and wastes money. So exactly what are we tied to? We need to try other things. So there are variations of the accountable care model. There's advanced payment ACO model, which is actually not a separate model. It's just that the Innovation Center has made some upfront payments and ongoing payments to particular types of ACOs, mostly small organizations and organizations in rural areas that help cover the kind of setup costs for putting together the ACO organization, and that will be paid back out of the presumed shared savings that they may generate down the line. But this is, again, a very different type of model than we could have pursued in my day, because we were explicitly prohibited from putting money up front in the expectation that a demonstration would end up saving money. There's the Pioneer ACO model, which is that is a group of 23 organizations that are more advanced, more organized already, and willing to take risk and in return for a higher share of the savings that they generate. So another initiative that's being tried, and it's currently, the applications are currently under review, so it's not being implemented yet, but is to focus on patients with end-stage renal disease. Those are particularly costly, and patients who are particularly dependent on the healthcare system. They frequently have lots of complicating comorbidities that either grow out of their diabetes or kidney failure or condition. So again, there's a lot of cost on the table there, that can be managed better, both to save the system money, but also to help these people get better treatment for the conditions that they have. There's the Medicare Healthcare Quality Demonstration, which is actually a demonstration that was legislated in the Medicare Modernization Act of 2003, and it was originally intended to promote broad system change. But one point to make, this demonstration is no longer active because it was a 5-year demonstration, but it raises a point that people have to face in conducting these initiatives, and it has to do with the kind of testing and evaluation model. And that is, we actually started this demonstration when I was at CMS, and when I went around to different groups talking about this. One question I got was, okay, so you've got this 5-year demonstration, you're telling us to change, completely reorganize the way we do healthcare, and the Secretary of Health and Human Services has a lot of power to change the way they pay for that. But it's a 5-year demonstration. Suppose after 5 years we do all this, and then you say, okay, well, we're trying something else now. Do we just like resume our places? I mean, what do we do? And that's one of the limitations with this notion that you've got a demonstration that you're going to do for X years, you're going to evaluate it, and you're going to decide whether it works. Is that you've got people here who are in the real world and who are having to decide what they're going to do in the long term. So again, shifting to a different model that that really says, okay, we're going to try something different, and we're going to keep trying it and keep working on it so that we get it to work. And you know, sometimes you're just going to have shut down initiatives after a while because you decide they don't work. But and I guess, you know, the Maryland rate setting system is one example of something that started, I don't think at the outset of the Maryland rate setting waiver that people expected that it would be in place for 35, 40 years. But it was something that kind of kept going, and there were adjustments made over time. And now, of course, there's a bigger adjustment being made to shift from a per case to an overall spending consciousness. The Medicare, there are several demonstrations that are referred to as bundled payment. The acute care episode demonstration is only inpatient hospital, but it includes physician services in the hospital, and hospitals who participated in this agreed to be paid a discount on the payments that otherwise would have been paid under the fee-for-service system. And that's been something, and again, hearing reports back from the participants in this demonstration, one of the things that they reported was that they felt like it was a success from the beginning, because for the first time, folks in the administration of the hospital reported that they were sitting with the physician staffs and actually trying to address a common problem in a common way. And that's a big step forward. There's several little of bundle payment initiatives that that Medicare is developing and implementing now, and there are different models that have different combinations of, you know, acute care hospital expenses only, acute care plus post-acute care, post-acute care only, and then there are prospective and retrospective payment models there. At this point, I should also mention that Rob has been mentioning gain sharing. There are a couple of gain sharing demonstrations that are in place in Medicare as well, and the distinction is frequently lost between shared savings and gain sharing. Shared savings is the sharing of savings with a payer by providers. The gain sharing is when providers get together, usually hospitals and their staff physicians get together to agree to reduce costs by doing things like standardizing their prostheses that they use in replacement surgeries. They can save a lot of money by, you know, by by getting volume discounts on those, and also really looking at which ones work best. And the hospital, in many cases, will agree to share the savings from those kinds of changes in decision making with the providers, with the physicians who are making those decisions. There's a lot of focus on trying to go beyond the hospital and beyond the physician office and look more broadly. There's an Independence at Home demonstration that tries to provide primary care in the home for Medicare beneficiaries with multiple chronic conditions. The Medicare Coordinated Care demonstration was one of the first broad attempts by Medicare to deal with coordinated care, and this is a perfect example of a demonstration that there's going to be an argument about forever about whether it worked. Only 3 of the 15 sites actually saved money, but service was improved across all 15 sites. And thankfully, the researchers have gone back and tried to dig up the elements of those demonstrations that worked best. And one of the things actually that was found was that coordinated care initiatives that were more closely aligned with the physician office tended to work better because it was more effective in engaging. They were more effective in engaging patients because patients trust physicians, and so there are lessons to be learned, even from demonstrations that don't necessarily work. But there's always a debate about whether a demonstration works or not. There's a Medicaid innovation that provides incentives for prevention of chronic diseases, and that's Medicare's work. CMS is working with 10 states to come up with different approaches for providing incentives to reach Medicaid beneficiaries before their chronic diseases arise and before they spike into very expensive and very debilitating situations. And there's also a broad, one of the things the Affordable Care Act did was created a Medicare-Medicaid coordination office. Because even though Medicare and Medicaid are housed in the same building on Security Boulevard, there is a shocking lack of conversation and mutual knowledge of the 2 programs, and particularly that affects 9 million beneficiaries who are eligible for both Medicaid and Medicare. So the Medicare-Medicaid Coordination Office has now developed an initiative that involves 9 different states in various stages of development to try to coordinate care better across the 2 programs. And again, nursing home patients bouncing back and forth between the hospital and nursing home is another big problem, and it's one of the problems that kind of highlights the dislocation between Medicare and Medicaid, because Medicaid generally pays for nursing home stays, but Medicare pays for the hospital stays for dual eligibles, and so you've got a lack of incentive for the nursing home to keep patients out of the hospital, and so there are initiatives to try to kind of combine that. And I remember that's another thing where the rules have gotten a lot more supportive of trying to develop these initiatives. We used to have to deal with a rule that the Office of Management and Budget had before they would approve a demonstration, that the demonstration had to be shown to save money in every program that was involved. So if you had a program that would involve more cost for Medicaid, but save Medicare many times that amount, you would have trouble getting that demonstration put into effect, even though it both came out of the federal budget. So, and of course, that was to the detriment of the care that the beneficiaries who depend on these programs receive. So that's, and of course, I have to mention the State Innovation Models Initiative, This is a very exciting program, and I know Maryland is working on their model. It's really great to have a explicit recognition that multi-payer involvement has to, is really necessary to make some of these things effective. As big as Medicare is, and Medicare is another big, Medicaid is another big chunk of the healthcare dollar. Still, if you have different incentives from public and private payers, you're going to have less effective initiatives to try to coordinate care. One thing that's troubling about the State Innovation Models Initiative is that Medicare is generally not involved in these multi-payer initiatives, and that's a real problem that needs to be addressed as these things go on. So, what are the lessons we learned from these things so far? Well, first of all, we have to remember that part of doing a demonstration or a pilot is to figure out that it actually can be done and how to do it. And what that means is that you have to be flexible in implementing, designing and implementing these things. And what that does is it drives evaluators crazy because you're contaminating their evaluation. But that's kind of tough because you're not working in a laboratory, you're working in the real world, and you have to make the adjustments you need to make something work. You need to have multi-payer involvement to make things more effective. You need to be open to different models because we have we can count the numbers on a national level or even on the state level, but even within a state you have different areas, and they say healthcare is local, and it's absolutely true. So you need to be flexible to allow for things that work in different areas. The innovation with evidence development bullet there refers to the fact that you need to be able to move from a very inflexible traditional evaluation model to a model that monitors the progress of these initiatives, and then be willing to make changes in them when things seem not to be working as well as they should be working, rather than just have an on switch or an off switch. And you need to be able to put an infrastructure in place that helps support the success of these initiatives. You can't just kind of say, okay, let it run and then come back to me and tell me in 3 years whether it works. There has to be ongoing involvement. And I think the Innovation Center gets that now, and I think a lot of private payers and a lot of groups of providers are getting that as well, that we really have a system that needs to change, and we owe it to ourselves as taxpayers and payers for health care, but most of all to the patients that the healthcare system is responsible for and is supposed to help to be able to do these things better. So I'll end with one of my favorite quotes about demonstrations and other initiatives. It was a quote from Franklin Roosevelt in his first campaign for president when he was talking about a much broader issue, the Depression. But he said, the country needs, and unless I mistake its temper, the country demands bold, persistent experimentation. It's common sense to take a method and try it. If it fails, admit it frankly and try another. But above all, try something.
Yeah.
So that's where I'll end. Thanks.
Yeah. Well, Stu, thank you. Thanks for sharing your experience and knowledge. I like the quote. I really like some of the key considerations and takeaways, and you'll note that some of those things were things that had already come up earlier in the day. So I thought that was great. And as you say, the existing system is imperfect. So yes, try something. And I think that as many of us know, Medicare has done and is doing more testing than ever. And I really hope that we can learn from those things. And with that, I think we'll turn it over to Phyllis.
Sure. So while the slides are coming up, I'll just start talking. Thank you for inviting me. And I think Stu has provided sort of a macro picture of what's going on. And what I'm going to talk about is the ground up or the more micro picture of improvements in care delivery that also save money. I'm going to talk about efforts that are largely both private and public. but arose some degree out of the private sector. And I'm going to focus on ambulatory care and what's going on in ambulatory care, and hopefully you'll see that there's a relationship between using some of the best practices from ambulatory care in conjunction with hospital services. I'm going to talk specifically about, let's see, is this going to work over here? You want me to use the keyboard? Okay. Okay. Specifically about what we've learned from the patient-centered medical homes, what also can be learned from Medicare's special needs plans, which are a version of Medicare Advantage plans that sign up to serve special populations, and sort of the conclusions from both, which I think you'll see are pretty similar. So what the patient-centered medical home aimed to accomplish, and has, I believe, largely accomplished from those that take it on, is to change the mental model of how to take care of patients from the sort of visit-by-visit, interaction-by-interaction model to a population health model at the level of the individual physician practice. Health plans have traditionally taken a population approach. They have members. They're responsible for that population. On the other hand, clinician practices operate traditionally on a visit-by-visit basis without thinking of the patients they serve as a population and how to advance the health of that population. So that's been the mindset change that we've aimed to achieve with the medical home, and I'm going to talk about what that means very specifically in a minute. Let's see. Stu mentioned this about sort of, how the population breaks down in terms of healthy and advanced illness, so I'm not going to go into this in any detail. I think the point has been well made. So I'm going to start out by summarizing the latest research on what the patient-centered medical home accomplished, and then I'm going to go into, what are the building blocks or the foundational elements that have led to those accomplishments. So this comes from the latest review of the literature by the, it's cited on the bottom of the next slide, the Patient-Centered Primary Care Collaborative, and these are findings that patient-centered medical homes continue to demonstrate impressive improvements across a broad range of categories: cost, utilization, population health, prevention, access to care, and patient satisfaction. We are getting more and more studies. The evidence is mounting that following the model decreases the cost of care, that it does that through reductions in the use of unnecessary services. That includes emergency department use, urgent care visits, patient admissions, and patient readmissions. And that's, again, by paying attention to the fundamentals up front that can lead to that decreased utilization and, frankly, better health. So we do simultaneously see improvements in population health. We see better control of hemoglobin A1Cs for patients with diabetes, increases in screening and immunizations rates, better controlled blood pressure, and better controlled LDL. Improvements in access to care is a key component, really paying attention to being able to do same-day appointments, being able to provide 24-hour care can make a big difference in reducing unnecessary utilization and keeping people out of the more costly environments. And improvements, and these are all, these accomplishments are reflected in improvements in patient satisfaction. So I'm going to go really quickly through the sort of building blocks of the patient-centered medical home. These are as reflected in the standards for NCQA's recognition program. We were the first to have that recognition program. I was the lead at NCQA in creating it. We built it off of the chronic care model. We worked with the primary care specialty societies, particularly the Academy of Family Physicians, American College of Physicians, and the American College of Pediatrics to build the program, and we really put together research about what leads to the most effective ambulatory care, including addressing the coordination of care issues, which are so important. So the initial standards require, again, knowing your population. So doing basic health risk assessments in the beginning, capturing patient clinical history, patient demographics, doing that, by the way, in electronic systems that you can then use, that you can then manipulate to reach certain population groups is very important. Then there's the individual care planning process and working with patients and their families to develop the individualized care plans and also patient self-management plans that go along with that, and utilizing community resources. Ongoing patient self-management, care management and patient self-management are very important. And then the basics of tracking information, and here's where the coordination of care comes in, tracking lab tests and other clinical results, tracking referrals, having systems in place to do that systematically and electronically, again, to keep track of the information and to be able to search it and sort it as you need it. And then systematic coordination with facilities during transitions. And this, frankly, remains one of the most challenging components of the programs. Many primary care physicians, I'm sure you're familiar with this, report not knowing when their patients are hospitalized, not knowing when their patients are discharged, real significant barriers to coordination of care. I think Maryland has taken some really important steps in that direction to address that barrier, but I can tell you in the rest of the country it's a huge problem. Let's see. So I mentioned ensuring same-day and after-hours access as important systems that practices put in place to, again, proactively manage the health of their populations and being able to follow up patients who miss appointments. So I very quickly went through. We can talk in more detail. The standards are available at no cost on the NCQA website, but I just wanted to touch on the sort of how do they do it? What are the fundamentals here? And let me move now to the challenges. What are the most challenging activities that practices face in adopting this approach to providing care? Using data to support population health is one of the requirements, and that means having the information about patients captured in structured fields electronically so that when you want to reach all of your diabetics who are not in control, you can search and generate a list and do the follow-up that will get them into control. Care management, again, due diligence to carrying out the care management process is important, and that means bringing together the pieces of information about an individual patient, sitting down with the patient and their family, developing a plan, developing the related self-management components, all very important, but nonetheless challenging processes, and referral tracking and follow-up. Those are important processes, again, to make sure that important information isn't falling through the cracks. So NCQA defines these three as must-pass elements, and that means these are standards within the program that all patient-centered medical homes must demonstrate. In other situations, there's elements that are voluntary, if you will. You need to get a certain number of points, and you can put together those points in different ways. But we had a multi-stakeholder advisory group that advised us. Our board of directors also approves the program, and they wanted it's very important to be able to say these are the absolutely essential components that must be there. Talking about the most challenging components, so from our data, the ones that less than half of the practices achieve full credit on electronic access. Now, hopefully, this is changing as more and more practices do implement and learn how to use their electronic health records. But still, for looking back sort of historically over our data, this has been an issue. Referrals, making maximum use of community resources, has also been an area where a number of practices have fallen short, if you will. And a third area, which is a newer area in the standards, agreements, establishing and documenting agreements with specialists, sort of this area of both the primary care physician and the specialist really having a solid understanding of what each of their responsibilities are going to be with regard to any one patient. Again, very important for continuity of care to make sure that one doesn't think the other is doing, that there's a full understanding. And certainly research has shown, I think, from the specialist point of view, that they often don't understand what's being asked of them and what their role should be. So let's see. The flip side, areas where more than 80% of practices achieve full credit under continuity, ensuring that patients have a consistent care team and a team-based approach is one that practices that become medical homes have mastered. Using evidence-based guidelines and having point-of-care reminders is another one, and management of medications. We've made great progress in managing the issues that can lead to medication errors if they're not handled properly. Let's see. So let me just go on to tell you a little bit from practices' point of view of what the lessons learned. This is a quote from a practice, and what it says is, you know, we had an electronic medical record, but we really didn't know how to take advantage of its capabilities. And I think, again, this is changing with the HITECH Act, but in the earlier days of use of electronic health records, people used them the same way they used paper records, and they didn't understand how you could use them to do population health instead of just looking at information individual record by individual record. And our standards were really designed literally to teach them how to do that by requiring, you know, show us examples of lists that you create with patients with different conditions and how you use those lists to provide care proactively. Team-based care is another component of success. You hear about practices that have the daily huddle, where they go over the patients that are coming in and what their needs are from a variety of perspectives, and using all of the staff, from the receptionist to the doctor in the practice to deliver, to get the information and deliver care efficiently. In terms of resources, successful practices have participated in a demonstration or a pilot program. There's a large number around the country, and what that generally means is that all payers in a geographic unit, or all payers minus Medicare, sometimes in a geographic unit, have agreed to come together and support practices to go through the process of becoming medical homes and to provide additional resources in one way or another for them to do that. And the success of the medical home is really due in large part to the payers in the community agreeing that they were going to reward one set success on one set of expectations of standards, as opposed to every payer imposing their own set of standards and, frankly, driving their practices crazy and diluting the message. So in these successful demonstrations and pilots, payers have come together, and there has been there are additional resources made available to the practices. Sometimes the health plans actually provide care managers that are embedded in the practices or that can be easily reached through the practices. So that's one kind of support, all the way up to increased payments for medical homes, and sometimes sliding scale payments. So, you know, there's three levels, and sometimes you're eligible for one payment amount as a level 1 medical home, and a greater amount as you become a level 3. Or sometimes the expectation is that you can get paid for being a level 1 in the beginning, but you must progress to level 3. But that has provided strong impetus to the practices to improve. The use of the quality improvement process is really alien to many clinician practices, and sort of the idea of introducing a very deliberate quality improvement process has been important, and has been important to sustaining the improvements and going further. So practices have really learned how to use a formal quality improvement program to improve and to achieve what patient-centered medical homes are supposed to achieve. So based on our own research, this is really just summarizing what makes a successful patient-centered medical home. We have had grant-funded research in which we have conducted in-depth surveys with the medical homes on the practice transformation process, as well as analyzing our own data. So health information technology, the ability to really take advantage of it is one component. Leadership, as always, is important. The leadership within the practice really needs to support and provide the motivation to change. And practice culture, team-based approach, using using a deliberate process to manage change has been very important. Formal approach to quality improvement, I mentioned team-based care, and provision of resources to practices to help them achieve these changes. Now I'm going to switch, and I'm going to focus from health plan perspective instead of a clinical practice, small clinical practice perspective. But I think that you'll see that many of the same processes are leading to good success from health plans that really dedicate themselves to meeting the needs of special populations. Medicare has a program called the Special Needs Plans Program, and managed care plans can volunteer or apply to be a special needs plan, and that means that you're going to focus either on the dually eligible population, the population with Medicare and Medicaid, specific populations of beneficiaries with chronic illness, or populations that are institutionalized in nursing homes. Those are the three types of special needs plans. And for this part of the presentation, I'm actually going to talk through presentations from the SCAN health plans, which are in Southern California, very successful health plans from a quality point of view. And I'm just going to use their slides to tell you a little bit about how they do it. So they stratify the population, what they do for healthier seniors, what they do for those with the chronically ill, and what they do for those who are very frail and most likely at the end of life. And you can see here the variety of services that they provide. Some of the services are the same across those different strata, and some vary by strata. But this idea of really thinking, again, you're managing a population. There's going to be some members that have relatively light needs, some members that have very heavy needs, and some members who really want to focus on palliative care, and thinking about that deliberately, and having care plans that for each individual that reflect that. So again, here's the spectrum services that they provide. At the top, you see the palliative care for the members with end-of-life needs. And at the bottom, the population health management needs, which focuses on the healthier sector of the population. These are all Medicare beneficiaries. Most likely have 2 or more chronic conditions under any circumstance, but still there's a range of need within that population for which the plan has agreed to care. And this is how they think about it in a very deliberate way. Going through, again, their slides presented at a CMS-sponsored conference just in January about their best practices. And again, you see staffing, which is really, again, a team-based approach, thinking about how to meet the needs of the individual beneficiary and also the range of assistance that the beneficiary might need. They do administer a health risk appraisal, and again, the best practice would be to think about the various modes of delivering it and how to reach the most patients through the various modes. Care transitions is always a big process, important process that requires very deliberate and systematic management. So there's different types of transitions. You can be transitioning from home to assisted living, or from home to a nursing home, or from home to a hospital, or from hospital back into the community. But we all know that there's a lot of risks in any of those transitions, a lot of information that needs to be coordinated and shared. And this is their summary of their best practices. And behavioral health, large number of beneficiaries do have behavioral health issues of one kind or another, and a lot of focus recently in focusing on how to bring together primary care and behavioral health needs. Information sharing, SCAN points out, is actually one of their most challenging issues, and there remains no standard platform for sharing information with providers, which is certainly the case in the vast majority of situations across the country. And we don't have interoperability. Again, I think Maryland's really notable for making important strides in this direction. But plans are creating ad hoc approaches to the information sharing, web-based sites where the different members of the team that are caring for a beneficiary can put in information, and that's what they need to do. So I'm going to summarize the conclusions. Really, these apply to both the special needs plans and to the patient-centered medical homes. I hope you'll see that this is not rocket science. They're basic building blocks, and that these basic building blocks do make a difference in the provision of higher quality and more cost-effective care. So components, case management, which means an individual hands-on manager who usually leads a team, but a hands-on manager that is responsible for identifying and coordinating the needs of the patient. Good patient education and self-management, making the patient and their family an active member of the team, very important. Medication therapy management programs and medication reconciliation after a transition. Major opportunities for errors, adverse reactions, all of that, and deliberate approaches to that make a very important difference. Primarily from the health plan perspective or the payer perspective, benefit flexibility, the ability to understand what services that might not be traditional benefits can really make a difference in the member's ability to stay in a less restrictive setting. This involves can involve assessment of the home, installation of grab bars, assessing the home for rugs that can be a danger for falls, all of those kinds of activities, and then ameliorative steps to address them can be very helpful. Tiered case management programs for the highest risk patients get the most interventions. Again, thinking about the population that you serve, stratifying them, and understanding how to best meet the needs of each strata, and better coordination between the primary care physician, hospitals, the plan, all of the players, frankly, in the care of an individual patient. Paying attention to that is very important. So with that, I will stop, and I hope that sort of provided a useful picture from the ground up of the building blocks of effective care. Thank you.
Yeah, Phyllis, that was great. Those are absolutely the building blocks as someone who just spent 12 years sort of coordinating care specifically for seniors with diabetes, heart failure, COPD, and ESRD. Those are absolutely the building blocks, and if we do those things, we'll be much more successful. And I could talk for a long time just in response to that, but I won't because we're about out of time. So I would like to just open it up and see if anybody.
So thank you, everyone, for those presentations. Nicole Stallings, Maryland Hospital Association. I think at the beginning of the meeting we heard that this was setting the groundwork. What is the baseline here, and knowing that the ultimate outcome is to come away with some recommendations. What might be helpful is to look at the demonstrations that you outlined, Stu, in your presentation, and also the existing PCMH practices in the state, and have an inventory of what's going on in the state, understanding that Maryland has been unable to participate in many of those demonstrations because we are not part of the IPPS system. So it might be helpful just to understand that groundwork, figure out where there are gaps, what's working well, and where we could improve so that we're not going into these recommendations blind. I would add two to the innovations discussion. One is the community-based care transitions program that was authorized by the Affordable Care Act. We do have one demonstration in the state. It's in West Baltimore. There are 3 hospitals that are partnering with a community-based organization and the local ADRC. And it's all about identifying those high-risk Medicare patients, putting a health coach into the home, looking at risks, and really monitoring and testing those models that at the end of the demonstration could be billable. And I think that's really important. And then, of course, we do have many CMMI innovation recipients here in the state that are doing a lot of good work that everyone might want to be mindful of as well. But thank you again for those presentations.
Nicole, that's helpful. Thank you. And I would point out that the joint meeting on the 27th, you couldn't tell it by looking simply at the agenda without understanding the thinking behind it, but that's exactly what we're going to do.
Okay.
It's sort of the purpose of today was to bring in more national experts, take a view of the national picture, and then the whole the panels we'll have. If you looked at your work plan, numbers 3 and 4, the joint meeting, the panels, those will be people like, people here and people from around the state that are doing stuff on the ground today. So the idea is to have panels of leaders of what actually is going on today.
I think that would be helpful in having those panels to kind of offer early lessons learned, but even just to have that visual of really what's going on in the state, all of it, understanding that you can't have a representative from every organization. We've started some of that work at the Hospital Association. I'm happy to share that.
That would be great.
Of course, some of this it's a bit harder to get your hands on. CMMI's website, you can really drill down and look at some of this as well. But even for the PCMH practices in the state, how many are level 3? How many are level 2? I think that would be interesting as well. Thank you.
Okay.
I just wanted to point out there's a decided difference between shared savings and gain sharing. There's a difference between shared savings and shared maintenance. If the shared savings, each year the target shifts, that we've done better this year, we got to share the savings, but now the target is harder to reach. that over time it'll be less and less to share. On the other hand, if the shared maintenance payment is based on medical loss ratios, that if you continue to hit a certain medical loss ratio, you continue to share in keeping people healthy, then you don't just have a 3-year program, which then you've gotten low-hanging fruit and now you're done, but you might have a program that you can sustain. But it's not just shared savings from year to year, which is pleasant and nice and clearly incentivize people for low-hanging fruit. But you also have to maintain that, which I think you need to focus not just on savings year to year, but on some other metric, perhaps medical loss ratio metric. Thanks.
Thank you, Barry. Scott?
Thanks. Yeah, I'm going to echo what Barry said and turn a little bit. We've been very involved with the PCMH program at Calvert. As an early TPR hospital, the hospital took the initiative to coordinate all the primary care practices. We had 97% of the primary care providers in one of the 2 programs in the state. And the hospital zones, the health system zone are all NCQA level 3 in the state program. A lot of the independents are in Care First. And the one thing that made them all successful is that the provider practices were funded. You know, in Care First model, the primary care doctors got a 12% increase in rate plus the opportunity for shared savings. In the MMPP program, they get the per patient, the per month to help fund the care coordination. When you're asking, especially in physician shortage areas, Southern Maryland, much of the state, to change how they're practicing and to invest in the infrastructure. My take on the NCQA standards, having gone through it for multiple sites, is a lot of it is about setting up the structure, the technology, the staff, the workflows, not necessarily the outcomes per se that's supposed to follow. But the key is funding it, because again, it's going back to Stu's point about jumping off the cliff. That there's got to be at least a hope that there's a rope there to climb down off from.
Can I just respond really quickly? The rationale behind a lot of the increased payment to primary care practices is that a lot of the services that you're expecting them to provide as a patient-centered medical home are not well reimbursed through the fee-for-service system, and so it is to pay for ongoing provision of those additional services. The focus of all the research on if you pay more for primary care, you then save on other services, then supports the payment to the primary care, shows that it's a good investment, basically.
Thank you. Well, I want to, appreciate everyone coming. I think part of my job is to keep us relatively on time, although, it's a little after 10, so no one should feel bad about, hanging up or leaving, but I'm happy to sit here for a couple minutes if there's just a couple more comments. I do want to encourage comments from folks that aren't work group members, and
maybe also the ones online, the work group members.
People on the phone, if there's people on the phone that have any comments.
Yeah, this is John Chassar from GBMC Healthcare. That last comment by our speaker, first of all, I want to thank the speakers. I thought they were great. But that last comment about payment to support PCMH, so GBMC, all of our employed sites are PCMH level 3. And it's not that there's low reimbursement for coordination. There isn't any reimbursement. So we now have embedded care managers in every site working across all payers. And there isn't any reimbursement if a care manager spends 3 or 4 hours with a patient. So we are very excited about the physician engagement work group as a vehicle to get us to a more rational overall payment system, not just for hospital payment. Right now, the scarce payment profit margin of GBMC Hospital is 100% going to the support of our patient-centered medical homes and our ACO.
Thank you, Dr. Chassar. That's helpful, and hopefully that's part of what we'll be able to enable. Dr. Kahana? Yeah, please. Yeah, come up to the mic. And Dr. Kahana, I would like to just thank Dr. Kahana for coming. We're coordinating. As I mentioned before, the MHA runs a Transitions of Care project, and Dr. Kahana is the chair of the clinical committee within the Transitions of Care project. So thank you.
Thank you. So thank you for inviting comment. I actually have a comment for all three speakers, and thank you for those lovely presentations. I want to start out with the WRVUs, and to just remind you that there are some practices going on in the community, not necessarily in organized medicine, but also in organized medicine, where salaries are being withheld. So you're seeing 5 to 10% withholds on whatever the base salary is, which is then paid back through achievement or enhancements of those WRVUs, and that is a common practice. That was my one thing to say about what's going on here, which was not on the table at the time. The second thing, I want to say thank you to Dr. Goodman. That was fabulous. I think as our state is looking at the more comprehensive global payments, that Bundle 2 and Bundle 3 are the two that I think are going to be most important for us to understand. I actually understand 3 better because I participated in review, but I think 2 and 3 is what we should be looking at, the early learnings, to see what is going to be adaptable to our particular scenario. And lastly, to Ms. Torita, thank you for that presentation. I want to let you know that as a result of Standard 5B, which is the referrals, we have started to see the emergence of some practices which are much less than desirable, and we're beginning to hear from our practices out in the community, especially the freestanding ones, that specialists want kickback. So in exchange for a written agreement with a practice, we've started to hear from PCMHs that a cash payment is being requested in sort of lieu of that arrangement, which will now encourage that particular specialist to work with a particular PCMH. So I just wanted to bring that up, and I know there'll be a future time when we'll share with you learnings from our program, but those were just early thoughts.
Yeah, no, thank you very much.
In looking across all of the discussion here, and thank you again for inviting me to sit in on this meeting. But I think one point that needs to be really heavily stressed, and it comes up in particularly in Barry's presentation, is we have a system now where we're paying for something other than what we want, and the way to reconcile, the way to get people to provide what we want is to pay for what we want. And it's very difficult to ask doctors and hospitals to act in one way and then pay them for acting in another way. So that's the alignment part of this as I see it. It's not just aligning physicians with hospitals. It's aligning the whole system with how the money flows, because there's a strong impetus to chase the money, and it's very powerful. And so what we need to do is really think about how we put the money where we want it to be, so that people follow it where they want, where we want them to go.
That's very much the job of the work group.
This is Ben Lowendrit. One thing that we hear a lot about, and I think the discussion today reflected that, is there a lot of discussion about aligning primary care physicians through the PCMH and other programs, and ACOs and the like. There's been very little engagement, seemingly, with specialty programs, specialty practices, either hospital-based, hospital-employed, to some extent that can get aligned, and certainly independent practices. And other than being seen as somewhat the drivers of healthcare costs, which it seems like sometimes it gets referred to that the specialist is where the money goes, even though it shouldn't. There's a lot of good care that's going on by specialty practices, but they aren't aligned with these goals. We've never been engaged to do so. So how, I would hope that part of the discussion would be, how do we engage and align not just our primary care, and not just our hospital employed, but the independent physicians that are in specialty care as well. Because there's a lot of interest in being on board, just no idea how to get there. And I think that's should be an important part of the discussion here, and not lost. So.
Absolutely agree, and I think you'll be pleased with some of the speakers from our next meeting. We'll address that issue specifically.
And we have a brand new patient-centered specialty practice recognition program, which has turned out to be, it's brand new. It was just launched last year, and it's turned out to be more initially successful than I would have predicted, actually. So, be happy to, you might want to look at that.
Yeah, great.
Yeah, this is Dr. Parabim. I just want to reiterate what he said about the specialty practices, because I've been specifically looking at, as a pain physician, looking at better care for pain management, more population-based pain management strategies. And we are confronted with some of the same costs as a specialist as a primary care physician. We're going to have to hire care coordinators, engage a larger population, engage in preventive, medicine, risk stratification strategies, and so forth. And there isn't really a system for us to build that infrastructure right now, or a program that's specifically targeted to do that. I don't know if you can comment further on that, Phyllis. I mean, because I feel as though the primary care physicians can control some of the costs, can improve some of the quality, but they're going to need to reach out to the specialists who are going to have to build an infrastructure to help them do that. And so far, my attempts, the data gathering, the care coordination, these are costs and risks that are going to be tremendous for us to take on, and we don't really have a program to reach out to.
Thank you. Dr. Haft, I think you're on the line and have a question or a comment.
Yeah, this is. Hello?
Yes.
Hi, this is Dr. Haft. It's really important to me to restate the fact that this is really the physician alignment and engagement work group, and I think as Paul Batalden said, every system is perfectly designed to get the results it gets. And our system that we've been living in for the last 50-plus years is a fee-for-service system, which is well designed to produce larger volumes and has resulted in great costs. And I think, as several people have said before, if we're going to align and engage physicians, and that's the role of this subcommittee, this work group, to get off of that very well-worn, very profitable track, there needs to be a potent incentive to do that. Because now, from at the trenches level, if there are not sufficient reasons economically to get off of the fee-for-service volume-based track, it's very hard to persuade individuals, groups, owners of groups, chief financial officers of hospitals and others to deviate from that. So it is just absolutely incumbent to, as we do our work, to get those very potent incentives sufficient to be distracting from this fee-for-service world that we've lived in, and driving toward a system that says what we want to do. If it's the triple aim, better health, better experience of care, lower cost, it needs to be exactly aligned with that. And anything else, anything less than that is really going to be insufficient, temporary, and unsustainable.
Well, Dr. Haft, I thank you. I think that's a good place to end. I think those were good words. I just, partially because we're late. We'll have plenty of other times together, but that was very well said. I appreciate it. We all appreciate it. And on behalf of the whole HSCRC team, we thank you for your engagement, and we'll look forward to our next meeting. Thank you.
Thank you.